Good afternoon. This is Dr. John Bennett broadcasting from sunny Miami. Today we have another mHealth studio show. We have the pleasure of having noted patient advocate Micheal Series. And Micheal is going to tell us about all his activities and about his company and where he's going and just the general status of patient advocacy in medicine today. Good day, Micheal.
Lovely to talk to you. And I'm on the West Coast today, so we're both experiencing sunshine.
Yeah, well, that's good. That's good. And you're in Southern California, correct?
Yes.
In Orange County. Okay.
Yeah.
Okay, Micheal, I guess it's a pretty broad subject, obviously, patient advocacy, and that's, being a physician. I really don't know too much about it. Could you just give us general strokes of what is patient advocacy, please, to start off thing?
Listen, I've been a patient for 30 plus years. I was diagnosed at 12 with Crohn's disease, and then intestinal failure and intestinal transplant. And I've engaged with the healthcare service as a professional for 30 plus years. And I suppose the term advocacy has become, it's gained momentum probably in the last 5 years more than anything. But really, for me, I think it's about participation in your own healthcare. It's the changing paradigm from healthcare that has been traditionally, I would argue, quite paternalistic. And, brilliant people like yourselves have, been trained to treat people like me, and we've had a passive existence in that relationship. Now with the world that's changing, with technology, etc., we have access to more things, and therefore we can participate more fully in our own healthcare. And I've been very lucky that over the years I've had wonderful relationships with the healthcare professionals that treat me, and I've been able to therefore play a greater role in my own care. And therefore, hopefully, being able to demonstrate for others that there is an opportunity for patients to help other patients and patients to help themselves to a greater degree than ever before. So for me, I just see it really as becoming part of the overall conversation in reality.
Would you say the creation of computers and the widespread use of computers came about concurrently with patient advocacy?
I think absolutely. I think what technology has done, I think the growth of social media, as an example, has, in a sense, it's done two things. It's given patients like myself access to information that historically we might have found difficult to get hold of. Mm-hmm. And it's given us a voice. And if you look at social media, it's enabled us to really democratize the conversation on healthcare. We're having a Google Hangout today. You go on Google and they can predict health trends. They looked at predicting flu in places. You go on Twitter and you watch the patient activity, Snapchat being used in hospitals now. It's that plethora of technology that has really helped empower patients.
Mm-hmm. Did it take a while to convince patients? I guess patients already use social media, so it wasn't a really big stretch to use it for advocacy reasons.
I think it wasn't a stretch for them to use it. I think it takes a bit of bravery and a bit of courage to put yourself out there, to ask questions, to go in search of information. But I think, healthcare for me is fundamentally about a relationship, and it's the differing relationships that you have, and social media allows them to grow. As an example, I have a PICC line in my arm. I inject medications intravenously every day. If I've got an issue with that, or I'm not sure what to do, I'll go on YouTube and I'll find some information from another patient, almost as my first point of reference before going back to the doctor or the nurse. And that's what social media has sort of enabled us to do.
Yeah, obviously you have a lot of experience in the Crohn's disease, inflammatory bowel disease, because of your own personal experience, which you probably will talk about. Getting down to the nuts and bolts of it, how does, like a Crohn's patient, what do you suggest a patient that have a certain disease, how would they start getting involved with social media?
So the first thing I would encourage people to do is go to the social media platforms that you currently use in your own life, or if you don't, go to the ones that are the most common to navigate. So Facebook is a great starting point for patients. Then I would encourage you to start looking for groups, and you can search for them very easily. Look for groups that share your common disease area. So if I look at inflammatory bowel disease or Crohn's disease, IBD, there are a lot of groups out there. And then I would say, in the first instance, I'd encourage you just to be a listener, just to be a keen listener, just read, just absorb the information that's coming. You will see that conversation ebbs and flows. A typical patient, I would say, dips into the conversation when they're in need, and then comes out again when they're feeling better, and then dips back in again. And when you feel confident, you've read enough, you understand a little bit of the characters, just post, just ask a question, introduce yourself and ask a question as if you were having a conversation with somebody next to you. And I think by and large, groups on Facebook, Twitter, places like that, that have other patients, are very good at self-moderating, are very good at encouraging others to share a conversation. And they're also very quick to stamp down on those that perhaps are at the more extreme end of their views, or perhaps a little bit critical. So the voice of the crowd, if you like, makes that conversation quite easy.
Yeah, I know when you said that, I thought of the stem cell community. You get some crazy stuff being said in some of those groups, but something like Crohn's or established disease, I'm sure that people welcome sources of information, because, like you said, patients have been dwelling in the dark, maybe looking it up in encyclopedias, and there never has been a time in history where a patient has such rapid access and rapid access to other people. Yeah, sure, you can go to your local support system. By the way, did you go to those like locally?
Yes.
Or?
Yeah, and I think what's happened with technology is that often the support groups, the face-to-face support groups, have become quite focused on a certain demographic and a certain age profile, and online communities tends to be a broader spectrum. But the truth is, there's nothing like face-to-face meeting. But I think it's not just, you referred to stem cell, but I think there can be hysteria in a lot of different groups. And every day I get somebody posting something about they've found a cure for Crohn's disease. And if you swallow 2 bars of soap and you jump up and down 14 times, it's cured my Crohn's disease. And I think you have to just be sensible enough to let those things pass you by and concentrate on the main discussion, because often they're posted with good intention, and maybe somebody has found something that particularly works for them, but that's not mainstay. And the other thing I would also say about these groups are, I feel very strongly you shouldn't be going on the groups to look for diagnosis or look for ways of changing your treatment without then going back to your healthcare professional.
Right. Yeah.
A lot of people go, oh yeah, well, I can see from that you should up your dosage, or I think you should take these meds. And the truth is, they may be right, but you shouldn't be doing that in isolation.
Yeah. Yeah, that's what when I myself as a physician, and a patient asks me, well, what do you think, I should do? For example, there's a good friend of mine that has some kind of rhythm problem with their heart. And I've had experience with someone that had a certain treatment for that condition that worked, but I didn't say, you need to have this done. I said, look, bring this to the attention of your physician, see what he thinks, so he can put it in perspective of your total history of health. And to give a shotgun kind of answer is difficult from the medical point of view, from the physician point of view also, as well as a patient point of view. Michael, I've had not nearly as much experience in the advocacy and patient support, but what little I've had with the neurological syndromes, because I love this platform of Hangouts, being able to interact with people like you from afar. And I really was trying to get this going with the support of neurological problems, because I don't know if it affects you as much, your mobility with Crohn's, but with people with neurological syndromes, they have a hard time getting out of the house, and they have
Yes.
a hard time going to these meetings that you talked about. And I see a place for video platforms like this to kind of get patients together to talk about the problems that are common to various neurological syndromes. Have you used Hangouts at all? And I know you haven't used it much with conferences. Have you used it much in Crohn's at all, or what? Or in your experience?
And I think exactly to your point. I think there are multiple disease or condition states where patients struggle to socialize and get out in IBD. If you think quite a large percentage of patients have ostomies, and that's a pretty debilitating condition. People don't want to go out, they don't want to experience things. But the beauty of Hangouts and the beauty of this is exactly what you've just said, is you can connect people from all parts of the globe together to become, if you like, a family and a support network. And I think that ability through video to be able to see somebody, talk to somebody, empathize with them, I think is so important. And that's where I love this technology. And I've had it before. I talk a lot to patients who just won't go out the house, or don't have, or don't actually have a circle of friends to go out the house to and talk. Right. Circumstances made them quite lonely, feeling quite isolated, and Hangouts and video calls are a gateway, if you like, to their lives, and we should be encouraging that. And I also think there's a misnomer going around. There's a vocal minority that turn around and say, oh, we don't, a certain age profile don't have access to these tools, so it's only for the youngsters, it's only for the tech-minded. It's not true. You sent me a link on an email, I clicked on the link, and we're talking together.
Right. Yeah, I'm a big proponent of this type of technology. And Michael, even physicians are resistant to use it sometimes. I know in some cultures, they don't like to have their video. I know in the Japan and China, we've had a hard time having this type of conversation with physicians because it's cultural. I think in some cultures, and people may be a little shy. They don't want to see the picture up there, but certainly it's useful, and I hope we get some traction with patients. Because, logistically, to go to a meeting, you got to get a babysitter. And a lot of these people are strapped for money. And you have to get a babysitter to go out. Or you have to get in their car. You got to get a ride. Whereas they can easily use this platform from their computer. And nowadays, most people, even older people, have computers. And
yeah. Well, you've got your computer, your tablet, or your phone. Even you can connect to. I mean, I think I read statistics that the grandparent generation is the fastest growing users of iPads and tablets. So, you could be sitting on your sofa at home and clicking on, and you're in a video conference. And no, it's interesting you touch upon the clinician pushback in some areas. So I think that's quite a common problem around the world, and I think in reality it's actually harder and takes more bravery for clinicians to interact in this way than for patients. For me, I just see this as part of my everyday life. I see this as another way of being able to help someone else, or share a problem that I've got with somebody else to get some feedback. I think clinicians inherently, you think about data protection and privacy and all the things that are ingrained in you as your training and as you practice, whereas I think patients are unencumbered. So I understand why it's harder for clinicians, and hopefully the world is changing.
Well, you mentioned mobility and the ability to use other types of video devices. We had a neurosurgery conference in India on brain tumors, and virtual. We did it all online with Hangouts, and we had one physician that was in Venice taking a vacation, and he said, "Well, all I have is my smartphone." I said, "Well, okay, let's try it." So he gave a presentation from his smartphone in a restaurant in Venice, and I was sharing the screen and putting his slides up. And certainly it would work for patients. Everybody has a smartphone. You can access this type of technology with a smartphone just as well as you can with a desktop. And you can, you see the person's face, you talk. So it can work just as well. You don't need a desktop. A patient can watch it and can participate in a group discussion through their smartphone. So I think you're going to see it used more often.
Yeah, I think the argument about lack of connectivity is a dying argument. The
Yep.
number of people that don't have access is dwindling, is shrinking, and probably over the next decade or so, it's going to be eradicated. If you look in far-flung places in Africa and places like that, often they have a mobile phone before they have anything else. They have cellular connection and a phone before a computer. So I agree with you. I think these mobile platforms are a great vehicle of being able to just connect each other.
Well, connection, Michael. I'm sorry to be talking so much, but I was communicating with a community in Livingston, Zambia. I didn't even know where Zambia was. I had to get a map out and look at it. But that's where Livingston met, Stanley met Livingston. Livingston, I presume. Matter of fact, they have a city named Livingston in southern Zambia. And I was communicating with a nurse from a clinic there, and I asked him, "What's the most common disease that people die of in your clinic?" And he said malaria, which, as infectious disease is still alive and thriving in places like Zambia. And I just happened to have met a person a couple of weeks ago that is involved in a program called MASEPA, which distributes malaria diagnosis and treatment supplies for free. And they'll go to your village, bring it, and they'll do finger sticks on the children, and they'll give the medicine. But this nurse didn't even know about that because he was not connected to the internet. I mean, he wasn't active looking around for programs. So just even the most basic connectivity can be fatal in today's world. In places like Africa, of course, it doesn't apply to the United States, but and maybe probably in England, but in places like Africa, poor connectivity equates to poor healthcare.
Well, the irony of it is probably the greatest adoption of technology is in places like you've described in Zambia and Africa, where they don't have access to anything else, but they've got a cell phone, and actually they're going to be the fastest users of Google Hangouts, of this connectivity, probably even before the UK and the US to some degree, because they actually got no other way of communicating.
Yeah. That's true. Michael, can you bring us through some of your projects that you're involved in to kind of show how you're impacting patient advocacy? 11th Health, I believe it's called.
Yeah, sure. So just to give you a bit of background, I had an intestinal transplant in the UK. I was the 11th patient to undergo one at the hospital in Oxford. There are only 2 centres in Oxford, in the UK, that do intestinal transplant, and I had an ostomy. And you'll know it, but for those that don't know what an ostomy is, it's where part of your intestine is brought to the outside of your body, and your output is collected in a bag known as an ostomy bag, colostomy bag, pouch, that sort of thing. And you know, I discovered actually there are about 5 million patients around the world that have ostomies. And those bags are collection vessels, but they leak and they can spill, and you need to know how much is coming out, because that goes towards how your gut is functioning. And you know, whether you're at risk of dehydration and kidney injuries, etc. And I'm lying in bed with these problems, and I'm thinking, well, if something could let me know when my bag is filling, and it could capture the data, I could be a more benefit to myself and more benefit to my doctors. And the truth is, I just assumed there was something out there, but there wasn't. And so it all started with buying gear. I worked with a friend and we bought some gear off eBay and YouTube videos and hacked together a sensor. And the starting point was a flexible sensor strip that was bought, came out of a Nintendo Wii hand glove, computer game hand glove. When you put your fingers in the glove and you bent your fingers, it sent a signal somewhere. So the principle was, if I could put a flex strip on a bag, and as the bag changed shape, the flex would change, send a resistance and send a signal. And that was really the start of my idea. And then if I share with you where we are today, if that's okay.
Okay.
So I'm going to pretend I understand the wonders of technology. And
there you go. Yeah.
This is our current website, 11health. And what you see in the middle is actually the first generation device that is just being updated at the moment. But effectively, it's a connected medical device that sits on the outside of any pouch, and then it uses Bluetooth technology, and it connects to your app so that patients can use it. It sends data to the EMR and the nursing station for nurses to look at it, and it allows real-time interventions from the dashboard. And so we have a personal app, we have a hospital hub, an app, and then we even do connectivity now through Apple Watch and things like that. And that's where we are today as a company. We are people are able to get insurance to reimburse for the device, and you can download and receive the insurance information that you want to. And where we're working now, we're working with a number of major centers to do clinical studies, and we're primarily looking at places like reduction in readmissions, particularly in the first 30, 60, and 90 days, where readmission rates are quite high. And then we're looking at improvement of self-management, HCAP scores, those sorts of areas. And we're working with Stanford and Mass General and University Hospitals Cleveland and Mayo to do various studies into the world of connectivity and bags. So we're a small company. We're a patient-led company, as you can see on the left side. We heavily involved in social media and connecting to patients. This was built by me, a patient. I'm not a technology. I'm not an engineer. We employ patients, and we make it quite easy for everybody to connect with us and share their ideas. But fundamentally, it's also steeped in a bit of clinical-based evidence, which I think is important to the community, etc.
Wow, that's the most social links I've seen of any page.
Well, listen, I figured it was pertinent to us today.
Yeah.
In particular, is and the irony is, we build the biggest community on Facebook. We use Twitter to have instant conversations. We use Instagram purely really for picture sharing and things like that. We Snapchat with nurses at times, particularly the younger nurses. We do Snapchat like hangouts almost. So very much at the heart of what we're talking today is that ability to talk to people.
Yeah. Yeah, that's pretty impressive, that website. You said the magic word for hospital administrators, cuts down on readmissions. I'm sure you found a willing audience there.
Yeah, and listen, I'm one of those patients that bounces in and out of hospital. And unfortunately, you know, if you're connected to a bag, you know, and outputs involved, it's gonna have a knock-on effect on kidney injuries and that sort of thing. And those are really expensive costs to the healthcare system.
Yes.
And there are simple things you can do to help prevent and for me as a patient, I think healthcare is moving towards an outcomes-based system, and technologies can help in that in a way, because what outcome is important to you as a clinician may be different to what's important to me as a patient, and therefore but technology can communicate that way. You know, we can use a bit of machine learning so that we can deliver the relevant data for the doctors to be able to interpret it, but we can deliver the same data in a different way to the patient so that you can understand here. And I'll give you an example. So patients don't really correlate volume to a number. They just want to know when their bag is filling and when they need to empty it. So on our app, we use a traffic light system, you know, red, amber, green, amber, red. You know, when it shows red, you need to empty, your bag's going to overflow.
Right.
But that red zone data, that data point correlates to a volume, to a mils that the doctor and the nurses would see on the dashboard.
Yeah.
And that's the difference. You know, you're getting the same piece of data but interpreted differently for a patient and for a doctor. And I think that's probably where we can do better at health literacy, and we can use machine learning and we can use technology to improve that.
Well, just the communication about what you're talking about. Social media gives a chance to have those conversations that you wouldn't get if you're probably reading.
Yeah, and look, you get a chance to debate it. You get a chance to discuss it. You get, you know, we could have which probably wouldn't be fascinating for many people, but for you and me, we could debate the value of understanding volume in output and what it means to you clinically and what it means to me as a patient. But the fact that we can do it like this, you're on the East Coast, I'm on the West Coast. I'll give you an example. When I was in hospital after transplant, you know, number 11, it's very early days. There's not a lot of data to go off. There was a query about whether I was in rejection or not. Nobody really understood how to interpret the biopsy. So my surgeon got out his laptop and we Skyped in a friend of his in Miami. We Skyped in another friend in Washington from my room, and he's having a conversation with 3 different surgeons in different parts of the world. He was in the UK about what's your view about Michael's biopsy results and what do you think? And 5 minutes later, a course of action is agreed.
Yeah. Well, that's
the benefits of technology.
Yeah, you know, that's fantastic. And I certainly have experienced that. I mentioned to you before we started the show that we're helping to arrange a neurosurgery conference in Yemen. And through social media and the power of Hangout, we're able to assemble 12 neurosurgeons from other parts of the world to come to Yemen virtually. Which is fantastic because, you know, there you are, a neurosurgeon in Yemen. You can't travel around a lot. It's dangerous. It's a war zone, but you're able to because you're able to bring in the minds, like you mentioned with the minds from around the world on your biopsy. You're able to bring in minds from around the world to assemble at a place virtually.
And I think listen, the cost of you getting on a flight and doing that journey and being there and taking you away from your patients and what you do, whereas you can deliver the same quality of presentation, the same quality of conference virtually. I don't know if you've seen or read at all about, there's a surgeon in the UK called Professor Shafi Ahmed. He's known as the virtual reality surgeon. And he did the first ever Snapchat spectacles surgery. And he's heavily involved in virtual reality, and his sole use for it is medical education. He wants to use it to educate people and surgeons around the world about techniques, and it's all done in virtual reality. And how cool is that?
Wow. Well, yeah, there's so much going on. It's pretty exciting. It's pretty exciting with artificial intelligence, virtual reality, augmented reality. It's to me, it's a great time to be a physician. But this is a joke. But, someone asked me, I told someone, well, my life's not going so well. I'm going to medical conferences, drinking too much, and chasing hookers. Well, now I'm straightening myself out. They said, what'd you do? Did you uh, give up drinking? I said, no. I gave up going to medical conferences. Now I do that from home, and I don't have to leave.
But it's true.
Yeah.
It's the way of the world now. I mean, and I love it. I love it. I mean,
You know, go ahead.
I'm not going to ever advocate for removing face to face, for removing that in-person connection, because that's so vital. That human to human element is so vital in healthcare. But we can be smarter, and there's a serious discussion, there's a serious debate going on in your country, serious debate going on in my country at the moment about healthcare and the cost of healthcare and how we keep things going. It always fascinates me that tools that you and I take for granted in everyday life, Google Hangout, going on Facebook, using WhatsApp, texting, whatever, are not used in healthcare.
Mm-hmm.
And the cost
that is strange. That is strange.
Efficiency savings that could just be adopted by using the tools that we take for granted in everyday life. I mean, if you told people, 30 years ago that you would be able to go to a hole in the wall, walk down the street, go to a hole in the wall, punch in 4 numbers and remove wads of cash and then walk back to your car, everyone would go, you're mad, there's a security issue, you're going to get mugged, who's going to do that? Right. Now it's part of everyday life. Why isn't texting your blood results from a doctor to a patient part of everyday life? Why isn't, sending an image of your x-ray in real time just part of everyday life?
Yeah. Well, I'm sure, David Doherty, he seems to be a big advocate or a big voice that, hey, the medical profession is not using social media. By and large, compared to other industries, it's really not being used on a wholesale basis.
Listen, I think rightly everybody gets worried about data protection. I think doctors also and nurses get worried about overkill from patients. If I open myself up to talking to people, I'm going to get bombarded, abused, this, that, and the other. And I can see the danger of that, but I think that's where it goes back to advocacy and what's the role of the patient. If we are going to use these tools, that we have to use them under a rule, under a code of ethics, if you like, a moral compass, which for me is based on mutual empathy, mutual trust, and mutual respect. Mm-hmm. Don't abuse the other person you're talking to. Don't invade on their privacy when, there are certain things. I'm not going to go on Twitter and go, look at the wound on my PICC line. Can someone diagnose if I've got an infection or not? Mm-hmm. And I wouldn't expect my doctor to tweet the whole world, Michael, go and take 5 milligrams of this and go and do that. Right. But that's not what it's there for. It's designed for conversation, for education, for conferences, for getting a viewpoint. I mean, I'll give you another example. When I was recovering from transplant, I had a really bad pain over my right eye. Nobody could figure out why. It was like this constant headache over my eye and whatever. And my surgeon said, I don't know, go on one of your social media groups and see if anyone else has experienced it. And I went on LinkedIn group and I posted this. And about a minute later, a lady came back going, I reckon you've got shingles in your eye. Mm-hmm. And I went out of bed and I run down the corridor and I say to my doctor, I think could this be shingles? He's like, God, you know what? I've been a doctor for 20 years and somebody gave you a suggestion I hadn't thought of in a minute.
Wow, that's great.
So, we can be better. We can do things smarter. That's, I think, my frustration.
Okay, well, maybe we're making progress. Now, one thing, Michael, you mentioned about the in-person part of conferences. You've been a speaker. I've been following you at Stanford, and that seems to be the apogee of conferences as far as patient advocacy and digital healthcare. What's that like? What's that like being there and taking part of that?
So Stanford Medicine X is the brainchild of a gentleman called Professor Larry Chu, who is for me, a wonderful friend, but also just a genius. I have to say, when I first walked into Stanford, it was pretty intimidating. I was this Brit,
I imagine.
got off a plane, walked into the campus, and it was pretty intimidating. But what made Medicine X so special was 5 years ago when it started, it did a power flip. It said, we're going to have an academic digital health conference, and the VIPs are going to be the patients. They are the keynote speakers. They are going to have the VIP treatment. They are going to sit in the front row. We're going to turn this round. And I was privileged enough to be one of those first patients. Now, 5 years on, it's become another family to me. And the conversation is not about making a VIP of anybody in healthcare. Actually, the model of care that's advocated there is this everyone included model, that we are all equal, we all bring something to the table. I'm never going to replace my anaesthetist or my surgeon or my nurse, but I've got a lived experience of my condition that adds value to my care plan. So I would say, walking into Stanford, it's this mix of Silicon Valley, high tech, aura. It's got an aura about it, but actually, when you peel off the layer, it's just human beings having a conversation.
Okay. Have you been in the hospitals around Stanford? Do they implement the things they're talking about at the conferences in their hospitals?
Yeah. So you do see exemplars going on. You do see change happening. I mean, probably one of the biggest examples, Apple's research kit, which is now used in lots of clinical trials, came out of conversations at Medicine X 5 years ago.
Wow.
The way anaesthetists talk to patients before they put them to sleep changed out of a simulation work that was done at Medicine X. So very obvious. And as someone that's had 30 plus surgeries, the moment before you're put to sleep is an incredibly scary moment. You lose control of your life, basically. And now under Larry Chu, he's like, at that moment, he now kneels down, so he's eye contact with the patient lying down, and he's like, okay, tell me what you understand about what's going to happen next, and tell me what your greatest fears are. Tell me what I can do to look after you when I put you to sleep, so that when the patient goes to sleep, it's from a positive perspective. It's a different. It's not just, right, lie down here, give me your arm. Now I'm going to do is I'm going to put this needle in, and you're going to count back from 10, and you're going to be asleep, and off you go. Mm-hmm. So we've seen real outcomes.
Good. That's good to hear. One of the things I would say is make sure I wake up. Please. Okay, Mike. Go ahead, Michael. Go ahead.
I know. I agree. I think that feeling of hopelessness never leaves you.
Yeah. Okay. Well, great, Michael. Thanks for taking time to talk to us today, and open invitation to talk whenever you want to talk, or whenever you have something to say, or any of your patient groups or whatever. And
real pleasure to meet you, chat to you, and have a lovely rest of the day.
Okay. Very good.